Please come in and sit in front from the coffee break. Please come in. I know there are very interesting parallel sessions, but we have to start on time. So I will first introduce myself. I'm Katerina Antoniou from Iraklion, Crete, in Greece. And I am the head of the Assembly 12 Interstitial Lung Diseases for the European Respiratory Society. And I'm here to co-chair with Edith Brown from the Scleroderma and Renzoni Association from UK. So we will co-chair this, I think, interesting session about what's new in ILDs. I'm very happy and very honored to be in this Patients' Corner, in this important World Symposium. And we have much more than 200 registered patients in this symposium, so very, very well done. So with no further ado, my co-moderator, Edith, the floor is yours.
Okay, thank you very much. Hello, everyone. Good morning. It's a delightful setting here.
Yes, it is like a picture.
It is beautiful.
Yes, it's a beautiful Prague.
My name is Edith Brown, and I'm from the United Kingdom, and I was diagnosed with scleroderma in the year 2000. So I've had a little time to get used to the idea, but since then my lungs are still very badly behaved, so I'm particularly interested in the presentations today. On my right, we have our local hero, Michael, who lives near Munich. Michael was diagnosed with scleroderma at the tender age of 31. And that diagnosis was a tremendous shock, and it had a huge impact on his life, his health, and obviously his career. But since then, he has proved to be a local hero, an international hero, and has dedicated much of his life to encouraging patients to be involved in scleroderma research, and also to encouraging associations to involve patients as much as they can. So Michael has an intriguing and quite inspirational story to tell. So I'm going to introduce you now to Michael and hear what you're going to say.
And the topic is oldies and goldies, unmet needs.
Yes.
Yes. So thank you, Edith, for your kind words. Very motivating. So you're here to listen to the news on SSc-ILD, also known as lung involvement in systemic sclerosis. So at the beginning of this session, I must tell you that you have to wait for another 10 minutes to hear the actual news, because my job is to provide you with oldies and goldies, the unmet needs in SSc-ILD. The unmet needs are old as well as new. They are still present, although they have been improving over the last years. Systemic sclerosis is a rare systemic autoimmune disease characterized by a high clinical heterogeneity, in which interstitial lung disease is one of the main causes of morbidity and mortality. Interstitial lung disease is very frequent in systemic sclerosis. Actual data show that about 60% of patients with systemic sclerosis have lung involvement, so it's a very, very important field. And systemic SSc-ILD is associated with a significantly reduced quality of life. Depending on the individual course of the disease, I told you before in the last session that scleroderma is a very individual disease, as you might know by yourself. ILD and SSc can develop slowly and very secretly. In this case, it can take years or even decades to diagnose a lung involvement. In other cases, especially in men, the disease can develop very quickly and aggressively, which means a substantial risk of irreparable damages to the lung and to the condition of the patient before effective treatment can be started. So early diagnosis of systemic sclerosis, I have to say before, has improved significantly in recent years, While the disease used to be recognized in advanced stages with damages to skin and internal organs, it is now possible to diagnose patients with Raynaud's phenomenon if they show scleroderma-associated antibodies and/or scleroderma-typical capillary microscopic changes that can be detected, so in your fingertips. The EULAR classification criteria of 2013 were a major step forward in this context. Early diagnosis enables the early use of current treatment options and can prevent damage. It also enables better monitoring of disease progression based on organ diagnostics and the autoantibodies detected. Speaking about whole Europe, there are still differences in every country which need to be evened out. Despite many advances in the understanding of pathogenetic mechanisms and clinical definition, the management of SSc-ILD is still associated with several unmet needs. I want to separate these unmet needs in three types: the pre-diagnostic phase, the diagnostic phase, and the post-diagnostic phase. The pre-diagnostic phase, which means patient has symptoms without knowing the cause. This is, I think, the worst situation a patient can be in. Limited disease knowledge among HCP, among primary care physicians and specialists. This is the problem of every rare disease. General practitioners are mostly the first to get in contact with a scleroderma patient, and often they have difficulties in assigning the symptoms to the correct disease. This is not a judgment, this is not an allegation. There are more than 6,000 rare diseases, and scleroderma is one of them, so of course, general physicians can't know every symptom of every rare disease. And this is what we are here for. The patient representatives talk to the medical profession about the patient's needs, and the medical profession informs them about the latest insights in scleroderma. That's the deal here in this Congress. I want to give you a brief example of a successful improvement in terms of diagnosis. In Germany, the German Scleroderma Association, several years ago, in cooperation with the medical profession, succeeded in having every medical student mandatorily attend at least one lecture about scleroderma during her or his studies. The second unmet need in the pre-diagnostic phase is the lack of accurate patient information. Scleroderma patients mostly must deal with the symptoms and the impact on their lives on their own. The pre-diagnostic phase is the time when information would be urgently needed, and without any diagnosis, it is not available for the patients at all because they don't know what to look for. So they search the internet. That's what they do. They search the internet for shortness of breath, for pain, maybe for bent fingers, tight mouth, disappearing gingiva, and so on. And they may find a lot of things which are inappropriate and don't lead to the target. Patients in this phase tend to be scared, they tend to be hopeless, and are desperately looking for help. They can be very vulnerable and are not seldomly exploited by wrong people promising salvation. This is where patient organization, as well as the medical profession, must step in. So awareness for scleroderma and its symptoms needs to be promoted and always repeated. Third point, delayed or inappropriate referral. Of course, in the period before diagnosis, it is important that primary care refers the patient to the right medical specialties, to do the right examinations, and to do the right treatment. If this is not the case, the patients miss opportunities to recognize the symptoms in a suitable time. A common example is the referral to an orthopedist for examination of scleroderma hands. Enormous damage to organs, especially the lungs, and the cardiopulmonary cycle can occur. In most of the cases, the damages are not reversible and lead to severely restricted availability for the labor market. They lead to high costs for the social system and the health system, and finally, of course, a limited quality of life for the patients, or even worse. So the second phase is the diagnostic phase, and there are also unmet needs in the diagnostic phase. In most countries, the diagnostic phase is coordinated by rheumatologists, who are also the main point of care. A combination of both rheumatologists and dermatologists for scleroderma would be ideal, as well as a multidisciplinary approach to analyzing the required body areas and to make validated diagnosis. Depending on the local health system of each country, organization of multidisciplinary collaboration varies a lot. Harmonizing diagnosis and the subsequent therapy is key for a better and quicker rehabilitation of scleroderma patients, especially when they have lung involvement. The sick can easily fall behind in times like ours, when the general focus is on other things like wars, high energy prices, decay of local industry, and many more. Hospitals have been changed into centers which are urged to generate profit for equity holders. Over the last years, we have seen local hospitals closing in rows. Specialists are getting rare. Young talent is urgently needed everywhere. Rheumatology is having a recruitment problem. Appointments for diagnosis or treatments have a waiting time between 3 or 6 months, which is a catastrophe, especially in the first years of scleroderma. So furthermore, healthcare practitioners issued the lack of national guidelines. That's my second point during the diagnostic phase, which would improve and harmonize diagnosis as well as treatment. EU guidelines are present, but national health insurances often, I would say mostly, don't accept non-national guidelines in non-national languages. National guidelines are now being developed in several countries. That's a very good thing. And the third point is patients stated difficulties also in the diagnostic phase as well as in the pre-diagnostic phase, obtaining released disease-related information. The third phase is the post-diagnostic phase, meaning the treatment of scleroderma. So when you finally have your diagnosis and when you finally have found your center of expertise and you finally have found your rheumatologist, there is still a lack of curative treatment. There is still a lack of specialized nurses and paramedical and psychological support. Patients and caregivers additionally expressed again the need for clear information on SSC, ILD, systemic sclerosis, interstitial lung disease. Meanwhile, we have one anti-fibrotic medical treatment which has been officially applicated for the indication of SSC, ILD, one. All the other medical treatments for scleroderma and interstitial lung disease, even if very effective, are still off-label. Off-label use means the use of medicinal product outside the areas of application, authorized by the national or European regulatory authorities. That's the definition of off-label. Sounds a bit complicated. In principle, doctors are permitted to use medicinal products beyond the scope of the marketing authorization. However, off-label use is only covered by health insurance in exceptional cases within narrow limits, and this circumstance often leads to difficulties in prescribing the right treatment and receiving it over a longer period of time. And this is crucial for every chronic disease. You have to receive every treatment over a long period of time. So patients must deal with applications, rejections by the health insurance company, entering objections by themselves, and so on, just to receive the life-saving treatment they would need. So I want to finish with a conclusion. The lack of disease-specific knowledge is a problem. Gaps in national healthcare systems and insufficient information and support for patients and caregivers were identified as unmet needs to ensure timely diagnosis, provide better patient management, availability and access to proper treatment, and to improve the quality of life in SSc-ILD patients. Thank you for your attention.
Thank you so much, Michael. I was very much impressed about the delay in the starting of your cure. And you are in Germany, a very central, country, big country. But we will talk further at the end. So we will have now two excellent physicians, one rheumatologist and one pulmonologist, Monique and Elisabetta. So, you, Edith, or Monique?
Very, very pleased to be able to introduce a wonderful speaker. Her name is Monique Hinchcliff, who is the Associate Professor of Medicine at Yale School of Medicine. Monique is going to talk about what's new in the pathogenesis of interstitial lung disease. And secondly, very important question, why are the lungs affected in systemic sclerosis? Thank you, Monique.
Thank you. Thank you for the invitation to speak to your group. I'll do my best to answer those two questions. The second one is particularly difficult, but I'll do my best. So again, I was asked to speak about what's new in the pathogenesis of SSc lung disease, and bear with me a minute. The pointer's not active anymore. And then why are the lungs affected? So I'm just going to get my pointer. So I just wanted to make sure that everybody was on the same page and that we know what we're talking about when we mention interstitial lung disease. Thank you. So on the left, you can see a CT, a computed tomography scan of a healthy individual. And you can see that most of the image is black, and that's because there's air in the lungs. And that's where the healthy gas exchange occurs, as we know. And you can see on the right a patient with SSc, interstitial lung disease. And you can see that there's the blurring of the black, so there's lots of gray, which is indicative of inflammation. And then you can see the honeycombing here, which is indicative of fibrosis. And so fortunately, we have a drug that was approved recently called tocilizumab, and it was approved for the treatment of inflammatory lung disease, so that it would be treating this haziness. And as Michael mentioned, we have an approved drug for the treatment of fibrosis, which would be treating this. So I'm bringing you data hot off the presses. This was published in 2024, January of 2024. And excuse the scientific medicalese language, but I'm going to explain everything hopefully clearly for everybody. So this is a heat map, and this is depicting gene expression from 3 different studies. So one important thing, I'm sure the same is true in Europe, but in the United States, if you get funding from the government to conduct research, you have to publish your data so that other scientists can use it. And so we searched the gene expression databases and found 3 studies that had looked at the gene expression of lung tissue from patients with scleroderma. And so you can see in this heat map, here are the controls. So these are healthy participants. and they're denoted in blue. And so every column that you see is a participant in this research, and every row across is a gene. It's the expression of a gene. So we have our genes, we have 30,000 genes. We all have 46 chromosomes. We have 30,000 genes, and not all of those genes are expressed every day. So you may, for instance, need to increase the gene expression of mucus proteins if you have a lung infection, for instance. And so this heat map is depicting which genes are being made and expressed compared to the group, and which genes are being underexpressed compared to the group. So hopefully you can see that there's a clear difference between the healthy controls and the genes that they're expressing and the patients with systemic sclerosis, denoted in red. You can see there's a clear color depiction of the pattern of gene expression. And so when you take those genes, many genes, and you plug them into analyses, pathway analyses, you can identify the molecular or what the genes are doing as a group. And so one pathway I want to draw your attention to is that there's a decrease in cell death regulation. So these are lung cells, and we're looking at the expression in those lung cells, and there's a lowering of cell death regulation, meaning that there's increased cell death occurring. And then I'll draw your attention to down here where we look at epithelial mesenchymal transition, and I will explain that in the next slide, and that's increased in patients with scleroderma. So this is, again, just showing you the pathway enrichment for this EMT is higher in scleroderma patients as compared to the healthy controls. And what does this mean? So epithelial cells, I like to think of as barrier cells. So they're on our skin, they're in our lungs. In our skin, they're square cells, and they protect us from UV light and pathogens like bacteria and fungi. And so they're tightly bound. They stick together, and they prevent invaders from coming in. So you can see here, these are epithelial cells. But in response to damage, these cells they switch their gene expression. So they turn off these cells, and they turn off these genes, and they turn on these genes, and they become mobile. So the cells in your lungs that are healthy, when there's damage from a microbe, a bacterium, or from scleroderma, they can become mobile and can move to an area where there's injury in the lung. And that's shown here. They get these actin stress fibers, and they can migrate. And so there's lots of potential triggers for this epithelial mesenchymal transition. And I should say, once they're mobile, they're called mesenchymal cells. So there's lots of triggers for this. One that I'd like to draw your attention to is this gastric microaspiration. So that's why we tell every patient with scleroderma to elevate the head of their bed when they're sleeping, so that they're not breathing in teeny droplets of their stomach contents, which of course, stomach contents don't belong in the lung, and they're going to create inflammation. And so here's, I think this also was recently published in 2023, and I like this schematic because I think it shows nicely how the epithelial cells, which of course in the lung are very flat and thin so that oxygen and carbon dioxide can migrate across them, and it's depicted over here. Here's the type 1 epithelial cell, the black nucleus, and you can see how tiny the cell is along here. And so these cells, when they're injured, undergo this epithelial mesenchymal transition, and they become thicker and they become mobile, and they secrete the collagen, the scar tissue formation that shows up on the CT of the lung. And this happens, we are not sure, but it could be something from the blood. So you see the blood vessels close by. This blue is the lung, and the yellow is the tissue between the alveolar or the air sacs. And I think it's clearly shown here. So here's the air sac. And then you have your capillaries, of course, that surround your air sacs so that the gases can be exchanged normally. And so this is healthy. And in patients with scleroderma, you can have a buildup of scar tissue formation within these air sacs. And that's why it can become more and more difficult to breathe. I will also draw your attention to this cell called a macrophage, which in Greek means big eater, apparently, I'm told. And those are immune cells. And so those cells are in the lung air sacs, and they're the first responders. So if there's any damage in the teeny air sac, they're going to be the first ones to sound the alarm bell. And so what happens with all of this, epithelial mesenchymal transition, all of this injury with the nice epithelial cells having to detach themselves and move to areas of injury. This is exhausting for these cells. And so as a sign of that, the chromosomes, they have these protective caps on the tips, and those are called telomeres. And over time, these telomeres keep getting clipped off. They keep getting shorter and shorter. And this happens as a natural process as we age. This occurs. But in patients with scleroderma, it occurs faster because you're exposed to so much injury so fast, and you're having to recover that injury over a short amount of time that most people respond to over a lifetime. And so they get clipped, and this is depicted here in green. So the intensity of the green staining is the length of the telomere. And so you can see how much there's lots of green intense staining here. And in patients with fibrotic diseases of the lung, like idiopathic pulmonary fibrosis or systemic sclerosis, you can see a lightening of that green. And that's quantified over here. So the telomeres are shortened in the lung cells. And that's a sign of aging of the lung. And I think this picture drives the message home quite clearly. This is Paul Clay with his wife. This is before he was diagnosed with scleroderma, and this was 4 years later. And you can see how quickly this disease caused him to age, again, because the cells have to repair so much injury. So the summary to this point is that the epithelial mesenchymal transition, the transition from one cell type to a different cell type, is occurring in the lung. And there's a link to aging. So these cells are undergoing quick aging. And I hope that was clear. It was a lot of science. Shake or nod if it wasn't. You can ask me questions after. I tried to explain things clearly. So now we'll go to the next, all this medical jargon. So fortunately, when we're inside our mother's womb, we drive these macrophages from the yolk sac. And I looked it up. I said, do humans have a yolk sac? And we do. Turns out we do when we're inside our mothers. So these macrophages go into the liver, and they go and they populate all the tissues in our body. So there's these first responders in every tissue. You can see the lungs, the liver, the kidney, the skin, the gut, the heart, the inside of your body called the peritoneum. There's these macrophages, and they're sitting, and they're waiting for injury so that they can respond to it and dampen it. So when we're born, we have these tissue-resident ones that are present in everybody, in every tissue. When there's damage, when there's an insult to the lung, we also, thankfully, our bodies can attract more macrophages into the lung to help with the repair process. And these we get from our bone marrow, and the monocytes go from the bone marrow into the blood, into the periphery, shown here. So they're the monocytes, and monocytes is just a different type of macrophage. It's a precursor to the macrophage. And once they get into the lung, they become these monocyte-derived alveolar macrophages. So those come from the circulation in response to injury. So if you're a smoker, you have lots of monocyte-derived alveolar macrophages in your lungs. And so we know that if we injure an animal model, if we give an animal model like a mouse, for instance, poison into the lungs, in a short amount of time, that the lungs will become very fibrotic, very laden with scar tissue. And so you can see this is a healthy lung of a mouse, and this is a fibrotic lung of a mouse. And associated with that is an expansion of the total alveolar macrophages. So the total macrophages within the alveoli, which are the air sacs, teeny millions of air sacs that we have in our lungs. So we showed this back in 2017. And so we know that these macrophages are honing to the areas of injury. Would this be a way that we could develop a new therapy for lung disease? So we have one that targets inflammation. We have one that targets fibrosis. Could we have one that targets the immune dysregulation that occurs in scleroderma? So that's what we're interested in. And so to do this, we measured the genes that are expressed in all the cells in the lungs. So we obtained these lung tissues from patients with who were undergoing a lung transplant, and the donor, the healthy donor. And so first you can see that all the cells that you'd expect to be present in the lung, we saw. So this tells us that this approach is a useful approach. Second panel in the middle, you can see that there's clear differences in the gene expression between the healthy donor lung and the patients with fibrotic lungs, and those are all different types of lung diseases here. So not just scleroderma, there's 2 patients with scleroderma that I referred for lung transplant, but there were other patients as well. But you can see clear differences in the gene expression. Oops, I should show you one thing. So this, you can see this big group of cells, the macrophages that I've been talking to you about. And so just keep that in mind for the next slide. So here we just honed in on the macrophages. So we're just looking at that one cluster of cells, and we further divide it based upon the gene expression into different types. And you can see that we identified 4 clusters of cells, and there are 2 clusters, cluster 1 or group 1 and group 2, that are really just primarily comprised of cells, macrophages that are fibrotic. And so you can see that here. They're only in the patients, the cluster here and the cluster here. Not a lot of tissue from healthy controls there. And so using this other special approach called RNA scope, we can look at the specific cell in the lung and the specific genes that that specific cell is expressing. And so here in yellow, you can see this pan macrophage marker. So CD206 is it's a marker, it's a cell surface marker of every macrophage. And this one, denoted in red, is specific for a sugar, SPP1. It's a sugar on the surface of macrophages that tells us that that's a profibrotic macrophage. That's a macrophage that's making collagen, that's leading to the changes in your CT scan. And so our hypothesis, our guess, is that we could partner with drug companies to develop a specific drug that would target this group of macrophages, because obviously we don't want to get rid of all the macrophages in the lung. We need them, but we just want to get rid of the ones that lead to fibrosis. So the conclusions is that we are working super hard to gain deeper insights into how lung tissue responds to injury so that we can design better treatments. I've hopefully convinced you that the lung cells show changes of older cells, like the clipping of the telomeres and the increased epithelial mesenchymal transition that shouldn't be happening as much as it is in your lungs. There's this expansion of alveolar macrophages from the macrophages being recruited from the bone marrow in response to injury. And there are specific macrophages that we can identify using special techniques that we think would be a target for therapy. We don't understand all the triggers of ILD, certainly not, but we think that, circulating factors, genetic predisposition, environmental factors, all contribute to the pathogenesis, to the reason why some people get ILD. Definitely esophageal dilation that most patients with scleroderma develop, and the chronic aspiration, breathing in of the tiny particles from the stomach is not a good thing. And again, nobody should be sleeping flat. And why some patients develop progressive ILD and others do not, that's a question that we're actively trying to answer. So hopefully this talk is encouraging to you that there's a lot of science being conducted using tissue from patients, using blood from patients, skin biopsies from patients. So thank you for contributing all of those tissues to us. And we'll do our best to find better treatments. Thank you.
It was a difficult topic, but I think Monique gave us a lot of insights from her research, and hopefully we will have more precision medicine for those patients with scleroderma and interstitial lung diseases. And now it is my pleasure to welcome Elisabetta Renzoni. Elisabetta is a patient advocate for many years in interstitial lung diseases. She's a clinical professor at the Royal Brompton Hospital. She dedicated, I think, her career to patients and to the research of pulmonary fibrosis, from biomarkers to new CT deep learning artificial intelligence. And most importantly for you, I think, is her research about non-pharmacological treatments such as the ambulatory oxygen use. So the floor is yours, Elisabeth, and then we will have
Thank you very much, Katerina, for that very kind introduction. And
it's also very, very well involved in the European Respiratory Society, where she did the chair of the CTD-ILD group, with Elena Bargali from Italy, and now both of them are in the committee of the ERS EULAR 50/50 guidelines that we are working on. Elisabeth, thank you so much.
Thank you. Thank you, Katerina, for that very kind introduction, and it's a real pleasure to be here with you and to talk about clinical aspects of Scleroderma ILD, and thank you so much to the previous speakers for doing such a great job. So these are my disclosures. Just to clarify that for the purposes of this talk, interstitial lung disease, lung fibrosis, lung scarring will be the same thing. So I'll go between them. So we've heard ILD is very common in patients with scleroderma, but there is great variability in its severity. It can be very limited and very stable, or can be progressive at different rates. It is the main cause of death, as we've heard, together with pulmonary hypertension. The main goal of treatment at the moment is to prevent progressive scarring. In some patients, we see also an improvement, and of course, we're hoping to improve treatments all the time. We've heard this already. So in interstitial lung disease, the air sac, the wall of the air sac is thickened by a combination of cells and connective tissue, collagen, elastin, etc. We've also heard that in the early stages, ILD can be asymptomatic because you have to have lost a bit of lungs before you notice symptoms. And then the first symptoms will be breathlessness when you're doing more strenuous exertions, such as climbing uphill, climbing several flights of stairs. And if the disease progresses, the breathlessness may be also present on walking on the flat for relatively short distances. It's important to recognize breathlessness can also have other causes, including the heart. We heard this morning a wonderful session on heart involvement, muscles and joints, loss of fitness. So there can be many causes of breathlessness. The two main methods we use to screen for ILD are CT and lung function. And a high-resolution CT is important because it provides greater detail of the interstitium. So it's a great way to look at the interstitial lung disease. We believe that all patients should have a high-resolution CT at the time of diagnosis. That isn't overwhelmingly done, but it is the movement. There is a movement towards advocating for a high-resolution CT in all patients at the time of diagnosis. And as we've heard, there will be a wide spectrum of severity. In the upper example, you just have this little tiny bit of reticulation, ground glass at the base here. The rest of the lung is fine. In this example, at the bottom, you have extensive changes of what we call ground glass and also traction bronchiectasis, when the airways are being pulled apart. An example is here by the surrounding scar tissue. And then we've got lung function tests. And of the lung function parameters, of which there are many, forced vital capacity, or FVC, and the diffusion capacity for carbon monoxide, or gas transfer, are the two parameters that are the most important for scleroderma. It's essential that all patients have lung function at baseline, so we have a baseline with which to compare in the future, and also to have lung function on follow-up. And the frequency will depend on the severity of the disease, on the risk factors, and the rate of progression. It's also important to remember that a degree of change between one lung function and another can also just be due to measurement variation. So if it's a small change, we would probably wait and see whether it is confirmed. So forced vital capacity is a measure of how much air you can blow out with a forced maneuver after taking a deep breath in. And gas transfer is a measure of how well the oxygen moves from the air sacs into the blood. And usually this test requires you to keep your breath, to hold your breath for 10 seconds. We also need to have hemoglobin, so we might need to do a little blood test from the fingertip to check, to correct for hemoglobin. So we've said the rate of progression varies very much between patients. So it can be completely stable, it can be only slowly worsening, or it can be rapidly worsening. And we're beginning to learn more about what are the risk factors that associate with a more rapid progression. And so among these, male gender, as we've heard, male sex is a risk factor, certain ethnicities, possibly age. Diffuse skin disease is more commonly associated with progression than limited skin disease, and skin scores. Also, ILD severity. So if at the time of presentation, the extent of disease is already, for example, more than 20% on CT, it's more likely that will continue to progress, reduce lung function at baseline, or if we've seen a short-term worsening in the lung function. Certain autoantibodies are more likely to be associated with progression, such as the anti-topoisomerase antibodies or anti-SCO70. And we've now learned from more recent studies that raised inflammatory markers like CRP in the blood can also be associated with more rapid progression. So treatments at the moment because the pathogenesis, like we've heard, is a combination of immune overactivity and fibrosis tissue developing, we've got two classes of drugs that we can use. One are the immunosuppressors that dampen down that overactive immune response, and the other is antifibrotic, so anti-scarring agents that at the moment slow down the scarring process. So when we're thinking with you about who needs treatment specifically for their SSc-ILD, there'll be a number of factors that we take into consideration. One is the presence of those risk factors that we've mentioned. The other is, how's the disease doing? Is it worsening? Is it stable? The other is, how severe is the disease? Because we've said if ILD is more severe, it'll be more likely to progress. And that we evaluate with lung function and CT extent. There are certain patient factors. So is the patient very elderly? What are the patient preferences? So of course, we would always need to discuss with patients our choices. And are there other illnesses that might condition how we treat. And then, of course, are there particular concerns for treatment? Do patients get lots of chest infections? So we would go for a lower or no immunosuppression, depending. And of course, in women of childbearing age, there are some drugs that either reduce fertility or can cause fetal abnormalities that we can't use, and that would also need to be discussed. So what have we learned from clinical trials? What can we treat with? So we've got the Scleroderma lung study 2 that compared mycophenolate. So these are two immunosuppressive agents, mycophenolate and cyclophosphamide. You can see here on the y-axis, it's the FVC, forced vital capacity. And you can see on average over 24 months, there's a small but significant improvement on average compared to baseline. So both drugs go with a slight improvement in the FVC after 24 months. They go with an improvement in breathlessness, improvement in skin scores, but the mycophenolate was much better tolerated than cyclophosphamide because of bone marrow toxicity, basically. Then we've got the FOCUS trial, and we've heard about that a bit from Monique, looking at anti-IL-6. And IL-6 is a very pro-inflammatory cytokine. In this trial called FOCUS, the primary outcome of the trial was actually the skin scores. But they had already, when deciding the study, decided that a key secondary outcome would be forced vital capacity, so the lungs. These were very highly selected patients, so they had to have early disease, diffuse skin disease, and raised inflammatory markers. And so we know from what we've said about the high risk factors, these are patients that are very likely to progress. And they were treated with either anti-IL-6 or placebo. And what happened, they weren't selected for ILD, but about 2/3 of patients had ILD. And what happened was, in red are the patients treated with anti-IL-6. In blue are the patients treated with placebo, so sugar pill. And you can see here, down here, this is the amount of milliliters that patients lost in the placebo arm. So on average, they lost around 1/4 of a liter just in 1 year. And that loss was almost completely eliminated with the tocilizumab, with the anti-IL-6 treatment. Then we have a trial with using rituximab, which is a drug that targets B cells. And this trial, which was a UK trial, Recital, was included different types of connective tissue disease, including scleroderma patients, which represented about 1/3. Again, the primary outcome was FVC at 24 weeks. And both cyclophosphamide in red and rituximab were associated with an improvement in FVC compared to baseline. And a manuscript comparing and looking specifically at the different types of CTD is being worked at the moment. So both drugs improved FVC, quality of life was improved by both drugs, and there were fewer adverse events in the rituximab arm. And then finally, we have the antifibrotic trial, so the Census trial, which was the largest trial so far done in patients with scleroderma ILD. These patients had to have, to enter the trial, at least 10% extent of fibrosis on CT. And they were allowed to have background immunosuppression as long as it was stable. And it turned out that about half of patients were on mycophenolate. And what the trial showed was that in the placebo arm, which is this light blue one, patients declined. They declined less than the focused arm, about 90 mils. And the treatment with nintedanib didn't completely eliminate progression, so patients still progressed, but less. So there was a reduction in the rate of progression. So it slows down worsening of FVC, but there is no effect on extrapulmonary features such as skin disease, and there are side effects that mean that about 20% in real-world patients have to stop the drug because of diarrhea. And then because they had half of the patients on mycophenolate, they were also able to look at the combination of the two drugs. And what they found was that the lowest drop, the lowest fall of FVC was actually seen in those that were on nintedanib and mycophenolate together, and they lost about 40 mils. The patients that were on either mycophenolate alone or nintedanib alone lost about 60 mils, and the patients that lost the most lung function were on neither drug. So from what I've said so far, and what the practice usually is among rheumatologists and chest physicians, is usually as standard treatment we would start with mycophenolate, unless there are reasons not to do that. In some cases, we would use rituximab or IV cyclo. In patients at high risk of progression, early disease, diffuse skin disease, raised inflammatory markers, we would consider tocilizumab. And in patients with significant fibrosis, nintedanib can be associated with slowing down of progression and can be used in combination with mycophenolate. Just briefly about hematopoietic stem cell transplant, it is an option that is, it can be used, but in a very selected group of patients with early diffuse skin disease that have not responded to conventional therapy. And the reason it needs to be quite selected, the type of patient that is undergoes this therapy, is that although it is associated with a significant improvement in survival long-term, there is a mortality, an early mortality associated with the procedure. But of course, in the right patient, and importantly, in the right center, so in a center that has much experience with this procedure, it is an option. And finally, lung transplant. If the lung disease continues to progress, lung transplant is an option. There's been this review in 14 European transplant centers. They have put together 90 patients with scleroderma that had lung transplant, and the survival rates were similar to the survival rates of patients with other types of fibrotic lung disease. But the esophageal involvement, the gullet involvement that we heard about from Monique, can often be a problem with suitability for transplant, and that's because post-transplant, if you have major aspiration into the lungs, that is a major problem for the transplanted lung. And of course, multidisciplinary care is essential. We've heard a lot from the first speaker how education is crucial. We need psychological support for patients, much more than we have right now. We need every patient to have access to pulmonary rehabilitation, supplemental oxygen, symptom control, palliative care, and of course, disease-modifying drugs. And so with that, thank you very much.
Thank you. Thank you so much, Elisabeth, for the treatment approach. I think it was very, very clear. I think we definitely have different phenotypes in scleroderma, lung disease. What do you do in your clinical practice between rituximab and cyclophosphamide? We saw the results. Do you prefer one in comparison with the other to start with? And when you evaluate the patient for initiating an antifibrotic, on the top, of course, of the immunomodulation, do you do according the census trial criteria, or you want a little bit more extensive CT? How do you do?
So, and then I'll be interested to hear what Monique also does.
At the other head of the Atlantic.
At the other end of the, yes, at the other side of the Atlantic. So basically, with regards to rituximab versus cyclophosphamide, first of all, in the UK, we don't yet have approval to treat rituximab as soon as we want, and so we can only go for it as rescue therapy at the moment, but we're hoping to change that. Is slow, yes. But rituximab has the advantage over cyclophosphamide in women of childbearing age that it does not reduce fertility. So whereas IV cyclophosphamide, because at the moment we would only use cyclo IV, it's no longer used orally because it's associated with more side effects orally. But IV, it will reduce the fertility. So in young women, rituximab has that advantage. And also, of course, it can be reused. So one can treat with rituximab every 6 to 12 months. The issue I can see with rituximab right now because of the COVID pandemic is it does make you more susceptible to not being able to clear the virus. But those would be the advantages. In terms of antifibrotics, again, in the UK, we're not allowed to start nintedanib straight away. We are only allowed to start antifibrotics if there is evidence of progression, not only in Scleroderma ILD, but across the different ILDs. So we would start nintedanib should there be progression. However, if I could use nintedanib, I think in patients with extensive disease or with other risk factors, there could be an argument for using it straight on. I wouldn't say for everyone, because it is a drug that has side effects and some patients find it hard to tolerate. But I think if you have certain risk factors, including extensive, more than 10% of fibrosis, I would consider it even upstart. What do you do, Monique?
We do the same thing. I really do not use cyclophosphamide very much at all. I believe it also decreases fertility in young men as well. Yeah. So we really try to avoid it. I think everybody gets started on mycophenolate mofetil, as you said. And then the decision to add on tocilizumab or nintedanib or rituximab is really on a per patient basis, with very careful discussions between pulmonary and rheumatology and the patient, because there are risks of being on these drugs, and so it's a very individual decision that we make. But yeah, we do the exact same thing as you do. We don't put patients on mycophenolate and nintedanib straight out of the gates, not only because it's difficult to get it covered, but we just, a lot of patients do really well with just mycophenolate, so why give patients two drugs? There's a lot of patients, don't progress, and so why give them more therapy that they don't need?
I think all of us agree regarding the multidisciplinary approach, and Elisabetta stressed that in the last slide. One more issue, I think, regarding scleroderma patients is the diet. And I know you have a special program at the Brompton with a dietitian. Is it a little bit different from the other ILDs because of the esophageal problems that the patients have?
That's a very good question, but the diet study that we're doing at the moment is for all ILD patients. So we don't have a specific SSC ILD diet. I'm sure we would benefit from having that because of the gullet involvement. And we have been carrying out a study of gastroesophageal reflux in ILD, and I was struck, and so every patient was having two gastric questionnaires, and I was struck by how many patients said they had either nausea or vomiting or bloating. I mean, the prevalence of GI symptoms, of gastric and intestinal symptoms is very high. So I'm sure that a dietary intervention that is targeted to scleroderma would be, but at the moment we're just doing a pilot diet study in all the... In the second phase.
Yes, exactly. Yes. And also we have the GI effects from nintedanib and the other drugs. So it is one more parameter that...
I just wanted to put a plug in. So this was taught to me by my GI colleague. So he introduced me to Gaviscon Advance and Reflux Gourmet, which I'm sure you're using. A patient told me about Reflux Gourmet, which apparently has a very nice caramel flavor to it. But both agents contain algae, seaweed, And when you take, so Gaviscon Advance comes as a liquid and a pill. You take it with every meal. Reflux Gourmet is just a liquid, but you take it with every meal. And when the algae hits the stomach acid, it forms a gelatinous raft on top of your food contents. So it acts as a physical barrier to reflux. So we have, proton pump inhibitors which reduce the acidity of what's in your stomach, but they don't prevent reflux. They just make what you're refluxing not as caustic or toxic. But the Gaviscon Advance, make sure you get the Advance, or Reflux Gourmet, or algae. I have one patient who just goes to a natural store and just buys algae. So you don't have to buy the brand names. But the point is that the algae, when it hits your stomach acid, forms this gelatin raft that acts as a physical barrier to reflux, which and I've had patients say that it's life-changing. So I really appreciate my GI colleague for teaching me that.
And you would do it because I tell patients to do it half an hour after meals. And instead, no, you would say, together with meal, 1 Gaviscon Advance. Okay? Thank you.
We learned a lot, and now the floor to Edith to do her questions, and of course to our patients.
Now, do we have any questions from our wonderful audience for our expert speakers?
Other parallel sessions.
Yes, we do. Oh, I need...
Hola. Hola.
Hello.
Soy española.
I am Spanish.
Tengo afectación pulmonar.
My lungs are affected, and I'm treated by mycophenolate. This caused lung cancer, and now my fibrosis, due to the treatment, has worsened. Am I a candidate for lung transplant due to the fact that I had lung cancer?
Controlado.
It is already under control, but am I a suitable candidate?
I don't, but I'm Italian, so I think I've understood that mycophenolate, you were started on mycophenolate, you then developed lung cancer, and the lung cancer has been cured, right? And you're asking about transplant. And I think the rule is 5 years from lung transplant. So basically that you have to be cancer-free for 5 years in order to be eligible. Is that what you were told? So was that the question? It was. Okay.
I don't think that the MMF was,
No creo que la MMF causa el cáncer de pulmón.
Scleroderma,
El escleroderma se asocia a la fibrosis pulmonar. Se asocia a un mayor riesgo de cáncer, pero...
yeah, sorry. So I don't know whether it was the mycophenolate that caused the lung cancer, but we know that scleroderma lung disease is more frequently associated with lung cancer. So that is also a possibility.
yes, not only scleroderma patients, but patients with lung fibrosis have 10 to 15% more possibility to have a lung cancer.
Are there any other questions from the floor?
Very good questions.
Anyone else?
Sí, hola. Hola, soy también
Hi,
española.
I'm also Spanish. My name is Maribel,
Soy también afectada por
and I am also affected by scleroderma. And I have a question.
Wait a moment, please.
Sí, hola. Yeah.
Hello, can you hear me?
Sí. No, me llamo María.
Hello, my name is Maribel. Can you hear me?
You can start your
Okay.
question. Yes.
Me llamo Maribel.
My name is Maribel, I am Spanish, and my question is the following.
¿Cómo se diferencia o
What
qué
is the
diferencia,
difference
hay entre una afectación
between
pulmonar de 40
pulmonary
años
affectation
fumando y una
due to 40 years of smoking and scleroderma? So what's the difference between these two affectations? Is this difference visible in the tests?
So the question was, what is the difference between smoking-induced lung damage and scleroderma-associated interstitial lung disease? It's a very good question, and you've done the work in emphysema. In scleroderma lungs, you can have both emphysema, and emphysema is the effect of smoking. So emphysema means the walls of the air sacs get destroyed. So you have less air sacs. And on the CT, you can see holes, basically. You see some holes where the lungs have been destroyed. Sometimes we see these holes even if people have not smoked. So it can be difficult to tell how much is related to smoking and how much isn't. But we can tell from the CT what is emphysema and what is lung fibrosis. And there are certain changes on the lung function that can also help us with that. So, for example, a greater reduction in the gas transfer with emphysema. But it's not a sort of black or white situation. It's not like, oh, it's all emphysema or it's all fibrosis. They are usually combined.
Yes, I think that it was a very good question. Elisabetta explained very well. We found like 10% of scleroderma patients who developed emphysema, and they were non-smokers. So maybe it is both autoimmunity phenomena and smoking-related epigenetic changes that causes this, let's say, CPFE phenotype, combined emphysema pulmonary fibrosis in scleroderma, a phenotype which is very, very common in rheumatoid arthritis, where both airways and lung parenchyma are very associated with smoking. From our patients, other questions?
Any more questions from the floor this morning? No? Don't smoke. And raise the head of your bed.
So I have a question. I have been having lung fibrosis or lung involvement for 17 years now, and it is quite stable. I'll take MMF and tacrolimus, but however, lung function is slowly over the years, of course, decreasing. So my question is, all the studies you mentioned, they always focus on patients with early disease and fast progression. So what about patients with late disease and slow progression? So does it make sense to intervene, to leave the MMF therapy as it is, and to intervene with an antifibrotic drug, for example, tocilizumab, just to stop this slow progression? Does that make sense?
So you're right that it isn't only the early stages where you can see progression, and you can see a sort of much slower progression. Of course, as we age, we lose a bit of lung function. So, 10 to 20 mils per year would be part of normal aging. And so over 10 years, that would be 100 mils. Over 17 years, 170 mils. 170 to 250 could be just aging. So, you would have to see, is that real drop? Is it over the last 5 years, for example, or did it happen before? But I agree with you that if you convince yourself with looking at the lung function decline, the CT can help to see whether there has been progression. There would be the rationale for introducing, whether you introduce tocilizumab, which is more of an anti-inflammatory, or whether you introduce nintedanib, that would be down, to discussions with your treating physicians. But you're right, it's not only the first years where you get progression.
Yeah, I would concur. We do have patients on 3 therapies. We'll have patients, because they're treating different things. You'll have patients on mycophenolate and tocilizumab for the inflammatory component of interstitial lung disease. And then you'll also have patients on nintedanib for the fibrotic. So, we tend to be aggressive. And if we see that in spite of immunosuppression, that there's still decline in lung function, we'll go ahead and start nintedanib. And we were successful in getting it approved, because that's the patient in whom nintedanib is most likely to benefit. We just want to keep you stable. We don't have to gain lung function. We just don't want you to lose any more, right?
And is this then a long-term therapy, or is it just for a certain period of time?
Therapy, yes.
Also long-term.
As we know from the study, Sensison, this is maintained, this effect is maintained in FVC over the years. So, yes, long term.
One thing about nintedanib, thinking again about the diet, there are some patients that lose weight on nintedanib. So they can remain on nintedanib. They really need dietitian input to make sure that you're not losing weight. So when we start nintedanib, we will always tell patient, let us know, don't wait until you've lost 10 kilos. Let us know much before that.
And another option would be, the autologous stem cell transplant, which, I've had extreme success with. If it's a carefully chosen patient who's healthy, and you go to a center where they do a lot of them, that can be a really effective treatment as well. And then there's new clinical trials that are starting in CAR T. So here I go with the science again. Chimeric antigen receptor T cells. It's a T cell therapy, but it's been used for cancer for a long time. And there have been published case reports that patients with systemic sclerosis, again, a carefully chosen patient, can do quite well with CAR T therapy. And so it's investigational, but there's lots of different sites. We're one of them, you may be one of them, that are, starting to recruit patients for that. So that might be another treatment to consider as well.
What about CAR T cells are also under investigation and approved in hematopoietic disorders. And what is your opinion, as you have shown us very good result and the scientific background of the monocyte macrophages? Are we close to a trial for, let's say, the targeting the antifibrotic macrophages?
I don't know if we're close to a clinical trial, but there's definitely agents that we're working very closely with the drug companies to pick the best horse, so to speak, because it's expensive to do clinical trials, and so you want to make sure that you have your top agent that you want to test. And so that's where we are right now in that development, is investigating. So these drug companies will have thousands of assets, they call them. And so in preclinical studies with mice and cells from patients, we do the research to see which is the best, maybe 2 or 3 drugs, and then we potentially take those into clinical trials. So that's where we are with that research.
So So much more research, education, and advocacy for scleroderma lung disease from our part. And now, Edith, would you like to conclude? Because we have also lunchtime, and diet is very important.
Thank you. Thank you very much. I'd just like to say a big thank you to all our speakers. It has been so illuminating and educational, and a beautiful balance between the science and the practical advice. I think the advice that I've heard this morning about controlling reflux, raising the head of your bed, that's probably been worth the journey for me. So I'm definitely going to incorporate that. So thank you very much to each and every one of you for giving up your time. And the audience as well for your rapt attention. Thank you.